So let's go through these questions here. Let's see. Make this a little bigger. There we go. We're now concerning ourselves with the muscles of the trunk. First, we'll look at the ones moving our head and neck around. Most superficially, in the back is a muscle that is anchored to the back and the head along the spine from that broad origin. So that's all the way from here, all the way down to here. Or here, on this one, from all the way here. What's this part called up here? Oh yeah, we just did that, huh? It's from the EOP. That's why I did that. All the way down on the spinous processes down, all the way down where the last rib attaches. That's that muscle. With this, and then it reaches to the tip of the shoulders. So it goes from here, reaches out to the tip of the shoulders. Does that make sense? So it attaches all the way here, and then it attaches again at the tip of the shoulders. With that, can you explain a couple of ways the trapezius moves the head around? Can you? Rotates head to the side. And it extends the head. The only thing I can't really see it doing is it's really definitely not flexing the head. Make sense? I always need to look it up too, though. Always. See, that's why I made these booklets so I remember. Rotate to the opposite side, yeah. So that's all those motions except for the flexion of the head. So that gets me to that concept. So if the muscle in the back here extends the head, brings it back when these muscles contract, where do you think a muscle will be that flexes the neck, brings the neck forward? In the front or in the back? The muscles in the back will bring it back. Where would you think the muscles will be that do this? In the front, right? There you go. See, that's how you look at muscles. You don't look at, I mean, you gotta you learn the names, but you try to understand the function. Oh, this I have to go next. I didn't change this part yet, huh? Oh, really? Slow. Another muscle that moves the head around quite a bit in the front of the neck. It anchors close to the midline of the sternum and the clavicle. From there, it reaches up to behind the head in the ear. Look at those attachments and visualize to approximate each other. That way, right? Close together. When I do that, I better understand the action of a muscle, which helps me clinically when I try to figure out which might have gotten hurt in an injury. What is the name of that muscle with those attachments? Sternocleidomastoid. Isn't that a nice name? Huh. I like that name, that's for sure. The name is sternum, chest plate, cleido, clavicle, collarbone, mastoid behind the ear. That's why you learned that landmark in the skull. So that's the muscle that is doing this, sticking out right here on the side. So when you oppose a muscle's action, a function of a muscle, the muscle contracts, and you can sort of isometrically contract the muscle, and then feel the muscle's attachments very often. You can't do it everywhere, but you can do that for a amount of places to sort of figure out what's that muscle doing. I have to do that when I try to study the stuff a little deeper. So let's look at the picture. There we go. There, clavicle, sternum, and then it reaches up. Pretty broad attachment. So these are fairly two superficial muscles that move the neck around. And then in the neck, we go from there, we go deeper into layers. You've noticed that there's a lot of layers to these muscles. The next to the muscle is on one side of the is on the side of the neck. Push your fingertips deep into the flesh above the clavicle and up side to side. Is it tight there? Painful? Yeah, no?
Yeah.
When you go really deep, it's like it's ropey, right? You go over ropey things. Yeah, if you're nervy, that feels electricity is like pain. That means you go over some nerves, you're rubbing over some nerve structures. Because all the nerves that go into the arms come out of this area from the spine. If you felt the nerve underneath your fingers, one that carries a message from the blah, 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 into the arm. What is this muscle that reaches from the side to transverse processes to the of the cervical vertebrae to the upper ribs? What is that called? Scalenes. One of my favorites. See, look at that. Right here from the tips on the outside into the ribs. And this is the nerves that come out of here. Right here. And so when that muscle is stiffy, nerves get squeezy, you get ouchies in the arm. I know, you can get a shot. But the other thing you can do is, and sometimes that ouch is carpal tunnel syndrome. So in the old days, you get this open up, but the problem's up here. And so that's why the ouch is an important ouch sometimes. So what you also could do is, if you think about this, and this I can bring this up clinically with confidence because it happened for so many years that I know it works. Arm is attached to the shoulder blade. Shoulder blade is anchored to the rib cage. Everything you do with this arm is going to yank on this. That's why you don't carry the groceries around without contracting any muscle, because it's yanking on this thing and it's pulling this arm down, and that's rotator cuff then, we get to that, that's frozen shoulder, and it's pulling on the shoulder blade on the rib cage, and it's yanking these ribs back and up and out, back and out. And then anything attached here is going to tighten up, because the muscles that connect into the ribs are like, whoa, we can't let go of this, we got to contract and hold this stuff together, and then all that gets tight, and then these muscles here, which go into the ribs, these scalenes, they get tight, they squeeze and hold together, that makes them bulgy up, that squeezes the nerves and pushes on the nerves, and then we get these symptoms here. So if this is really fiery, and this is really ouchy, that's it. Then this gets ouchy at some point.
Does this help or make it worse when you do this?
Well, you know, they roll the shoulder back. That's definitely helpful. I mean, that's where that, you know, the postural exercise we did, that's where that comes in long term. That's that one. And so, you know, it's one of them, but it's hard. I mean, it's tough. I have a drop table. And so it's an earthquake method, you know, in California. It's a table that has a piece that goes up. The patient lays on it, it goes up, and I set a tension, and I push it down. I lay the patient sideways, the head up here, this one right there, and I put my arm right here, and I go boom, boom, boom. I push it down, push the table, and it makes a lot of noise, but it's very gentle. And then slowly the rib cage comes back together, and these soften up. It's very interesting. Because the other thing when you get, for example, you got a car accident, then it really messes you up. Because you like hold the steering wheels, and you get slammed from the back, and the whole force goes in you, and this jerks all that around, and that's a lot of times we get the whiplash, the back and forth to the neck, but also here we get very iffy. But anyway, that's where the scalenes come in handy. Oh, you sidetrack me now. I do that to myself. Scalenes. Longus coli, also interesting. Is there a message on is there a question on the longus coli? I don't think so.
That's the next answer.
Is it? Oh, there you go. That's usually not taught in the beginning class, but it's an important one. Next muscle deep in the front of the neck, it gets injured during a car accident when one's head doesn't touch the headrest. Oh yeah, I wanted to put that in there because I think it's important. When I took a seminar on whiplash, we were talking about that. And so if you're driving, so I'm in the seat driving down, the headrest is here, my head is here, and I get hit from the back, my head does this. And so it overextends, and so it yanks back. So all these muscles in the front they're gonna not like that. And the deep muscles in the front are right here on the spine, right here in the front. And they get injured in that moment. So that's when you have a head on the headrest and you get hit. You don't do this motion as much. That's much more protected. You might go forward and then back. Yeah, I mean, definitely. But the first one is that initial back that's really, really toxic. Apparently. Yeah, see, here's a whiplash. Anyway, and that breaks, and we don't like that. So that gets really tight. So that muscle is the longus colli, right? So that's a deep, deep one. So when I drive, of course I forget, right? But I always try to, like, when I remember, I'm like, is my head touching the headrest? Is my head touching the headrest? It's also a good place where I can do sitting up straight exercises, like double chin and nobody's seeing me. Except when you see somebody drive by go like that, but no. We have a few more places in the back. Right underneath the occiput, there is a group of deep laying muscles that help move the head and the neck. There are also some neurologically wired with the eye movements and deeply connected strong fascia. That's that collagen-filled ligament-like connections through the whole body. That back line that I was talking about that goes around here. These deep, deep muscles. What are that muscle group called? Suboccipital triangle. And so that muscle group right here is deep in the occiput. And so that sometimes in massage you get people that, like, you lay down and you have these people that put their hands deep under the occiput and you just sort of sink in slowly and slowly and slowly and find little fibers. I mean, I had a guy, literally, he had to sell his business because of a car accident. He hit his head with a windshield, not good. And he got all the medicine he needed. His wife is an MD, with Sutter, and so he had all access, but he would get neurologically tested and tested and tested, and then he was wiped out. He couldn't play Scrabble for more than an hour. He would have to take daylight breaks. You know what changed him? He and his wife say, I massage this down in here. Slow and deep, 20 minutes at a time. Not like a whole body massage thing, just this very gentle at first. And that loosened up enough that it I don't know. Clinically, if I make my flow chart, what do I do with what? It's like, I don't know if that makes sense to just hang out with somebody and doing that for 20 minutes, or if I need to do a whole bunch of other stuff. But when that's what it needs, and that's what it needs. And so this is a very interesting area. So if you like massaging, that's why that move is very good. And these muscles are apparently the reason why when you throw up a cat into the air, it lands on the feet. It doesn't land on the back. And so it orients itself with the eyes very much in space, and then these muscles contract and they pull that back line and pull that the cat lands on the feet. And we got a little bit of that too. That's why when you lay in bed and you watch TV, you're not as relaxed as when you close your eyes and just listen to TV. If you do that. I fall asleep at that point, but that's why I brought this. It's a very interesting muscle group. That's the deepest. So when we look at that, I wanted to stay on that for a moment. When we look at that, that's the deepest layer. That's the front layer. We had the most superficial layer. So most superficial, and in the back now, and the deepest, and now we have one in between, the layer in between. And I don't know if I have a question on that. Let me see if I have a question on that. Is there a question on that?
Which one?
Yeah? Okay, let's see. Next. That's pretty comprehensive, these questions, huh? Jesus. Didn't expect that. These are a long time ago now. Overlaying those muscles, underneath the trapezius are a set of posterior back muscles. One row straight up and down, medial, laying medial, and the other one's fibers are more oriented diagonally from the midline towards the mastoid. So when we look at those, let's do this. One goes mostly up and down, maybe slightly from the outside to the inside, some fibers, very slightly, not like from here. But the other ones go more from the inside a little bit to the outside. And so those are underneath the big trapezius muscle. But then those also move the head around in different angles and different positions a little bit and help with that motion. Those are also often getting tight. And I massage those, I massage deep in here. That really feels good too. Very like they lay face up, but it's like right in here. They love that. You can do that for a long time. All right. So, what are those muscles? Can you name those two? Just what's that? Can you name it? Semispinalis and splenius. Shut up. See, when you see here this word capitis, it's like, why do we need to say for capitis? Why don't we just say splenius? So when you see, like you have that, sometimes you have like gluteus maximus, and then you have another one called gluteus medius. You heard of that? Yes. The word maximus only needs to be there to differentiate it from something else. So when you see you have the word capitis, you think there's another one that's called splenius. Why would there be two words for it? Why would we say capitis? There's also one called the cervicis. And so when you see that, you think, there's another one. And in further studies, and the other one would be called cervicis. I didn't differentiate them on here, but I think in the picture they might be differentiated between the capitis and the cervicis. Mm-hmm. So that's just another food for thought. There's a few places where we see it. We see it in the glute. We also see it in the rhomboids. We're going to get to that in a minute. There's minors and majors. All right, so that's that. Look at that. Now we're going to go to the back. We find some superficial group generally reaching from the pelvic area upward. Some muscle fibers stay medially, reaching up vertically, while others reach laterally onto these ribs. So superficial muscles are concerned with larger movements such as bending or trunk rotation. Can you name that muscle group? Which ones? Erector Spinae muscles. There you go. Erector Spinae muscles. So this one, what I wanted to talk about is when we look at layers of muscles in the back, we can see that pretty nicely. We got this big layer of muscle that is the Erector Spinae right here. That goes, some are straight in the midline more or less, some a little bit more lateral, and then some go more to the ribs. But they're all long muscles on the superficial end. Deeper underneath that, we have deeper muscles, like really deep muscles, and they go from part of the vertebra below, like almost the transverse process, and they reach up to the spinous process of a couple of vertebrae above. And then we have even deeper ones that go straight to the one above. And so when these muscles contract, they, like from a big motion perspective, they just move a couple of vertebrae around down in here because they're that small down in here. When the bigger muscles contract, the ones that are more superficial, they move that whole trunk around. And so the more superficial muscles are most likely involved with more global movements, and the deeper muscles are more with stabilizing structures, generally speaking. And so that's what I wanted to mention with that. Did you like that arrow? I put that in there. Took me an hour. Not quite. I know. Really trying to be perfectionistic. In my own way, at least. All right, let's see. We got a few more. Deeper than that, okay, that's what we talked about. Deeper than that is a massive layer that are attached to different parts of the vertebra. Some span from the outside of the vertebra, the transverse process, below and reach diagonally towards the midline, the spinous process for vertebral system is higher. Function of these deep muscles is crucial for low back stability. Again, these are postural, deeper muscles with more smaller motions. There's more postural stuff than bigger global motions. That's more stability and protection. And this one is the main one to activate and strengthen any low back ailment. What is that muscle called? A multifidus. So I bring this clinical thing in because we have shown that if this muscle is not firing, and the multifidus is like deep, it's deep in here, is this deep meat. So it's right here, it's this deep meat. This is an MRI, you see this is posterior, that's from the back, that's the front. So that's anterior. That's the multifidus in a healthy subject. We have shown, this is an MD study, we have shown that in a back pain subject, it looks more like that, and that's white. White is fat, not belly fat. Fat instead of muscle. Fat is cheaper than muscle. Muscle needs to contract, work all the time. We don't use that. When we don't use that, we put it away. We don't need it. And so the infiltration is with fat. The good thing is you can bring it back to this. But you got to do some work with it. That's why that muscle is so crucial, because in every low back pain person, this is wimpy. If we show that orthopedically, we need to strengthen this muscle and then the transverse abdominis, which I think comes up in a minute, or in a couple minutes. And that's why there is this exercise. So that's why that's there. So just a couple of tools maybe. I mean, again, the medical system, the way we have it, is a catastrophe, not because the doctors don't like it to do it differently most of the time, but it's a catastrophe because it does not treat some of these ailments properly, because it treats them passively. It gives you the pills. And then when I look at my mom, it's like, you know, you can be limping around your whole life when you're at that age, but you go with active stuff, and she's just going hopeful stuff, because we, cheer her on or something. And her husband, her own thing, she's really good at it. But you know, it makes a change in a few weeks in a 76-year-old woman. And you got Baker cyst, you got meniscus, which is surgical stuff. It's like very interesting. So this is not what you get necessarily from everybody when you go to the MD at Kaiser, because there's it's a different need. You need to cure right now. What do you need to go back to work? Well, you need the ibuprofen to go back to work. Or maybe you get a handout, but doing the handout is often left to us, and that's where the problem comes in. That's why PT is actually so crucially good, and we should take advantage of it when we get it offered. I often we blow it away because, he's going to get better on his own. Because it's a little bit of effort, but it's really, really helpful. So this is one that's crucial, extending. This is the multifidus, doing this extension over a non-firm, an exercise ball is wobbly. When you do exercises on something wobbly, it enhances your exercise outcome. Because you have to integrate the wobbly. The brain has to be more alert when it integrates the wobbly. And technically speaking, that means you have all these nerve fibers that we find that are in fascia now, that we're learning about. They get stimulated and activated and feed back into the brain. And I mean, I have technique that I stimulate muscle attachments with different parts on the skull, and those muscles turn back on. It's like, I don't understand really how that all works. But we know it works, and now with more fascial studies, we get more reasons why it works. Those kind of things. So that's interesting. So anyway, food for thought. I know, it's my own little pep talk.
So that was what just came out in 2007?
Well, a lot of that study started being boosted, yeah. A lot of that stuff started after that Harvard. Robert Schleip is a German guy, and he was one of the organizers, and I've listened to some stuff of his, and he's a very funny, dry German guy. He's like, these science people, they take it and run with it. And thank you so much for doing that, because the science gets more boosted, and we're learning stuff like that. I think that the multifidus I learned the multifidus stuff when I was in school, when I was 01. Finishing, so I think late 90s was much more already in that arena. Then it was more with the ibuprofens, not where the problem comes. You know, how much ibuprofens do damage to the elderly in terms of the gastrointestinal system. And of course, now we have the opiates, where we don't have to go anywhere to the NSAIDs, we just have the opiates to talk about. Looking at a chest. Okay, now we're moving here, huh? Looking at the chest in the front of the guy guides us to the muscles that lie deep between the ribs. There's two layers, an outside and an inside. Which of the two helps us raise the rib cage up? By doing that, increasing the lung volume. Which one is that? External. External, reach it up. Internal, bring it down. If you look at the model, I got it on this model here. We're going to have them on the tables. I just didn't want all these things standing there and people looking at the screen. On the side here, we have the ribs. And we have the ribs that, here on the outside, you see the fibers go a little bit this way. And the muscles here are actually attached on the rib above, and they reach to the rib below, a little more medially, and they grab that rib and reach it up and pull it up. So all those ribs get pulled up. And so the external intercostal muscles, they pull the rib cage up and out and enhance the volume that we pull the rib apart and make the volume bigger.
That's when you breathe in.
When you breathe it in, the rib cage expands, it gets bigger. And the lungs are attached to the rib cage. And so with that, they're suctioned onto the rib cage, and through that motion, they get bigger too, and that brings air into the lungs, and that's the breathing in. So the big muscle that does that is coming up. The external intercostals inhale. The internal intercostals are the ones right next to it. They are actually attached on the rib below and reach more this way, a little more medial upward. And they pull the upper rib down, and they sort of compress the rib cage that way. And so those are the internal intercostals, and they're helping in expiration through that process. I know, cool stuff, huh? So intricate. How we work. Next muscle covers the rib cage from underneath. It's often referred as the parachute-shaped muscle because it reaches from deep below into the lung cavity. When it contracts, it shortens, which moves it inferior. By doing that, the lung volume increases, and since the lungs attached to the rib cage and this muscle, it makes us inhale. What is his name's muscle? What is the muscle? It's the diaphragm, of course. That's called the diaphragmatic breathing. And when we go back to this, that's why I put this up. So the diaphragmatic breathing is very important because, why would that be? Because if you think about this parachute goes down and flattens out. Look at how much lung volume you're going to get from that. Compared to a little bit up here. So, and that's belly breathing. Oh, we got to stick the belly out. Shit. We don't want to do that. At least at home. There you go. So at home, you're gonna take a book, lay down, put it on your belly by the belly button there, and breathe up and down. And see you go up and down. And then you fall asleep. Well, it depends how much you study, you know. I know. All right. Diaphragm. I think that's good for a diaphragm. Oh shoot, I'm making this. Oh no, we had a quiz in between, so we're good. Come on. Lastly, when talking about axial muscles, we'll discuss the front and sides of the stomach and the gut muscles. Aha. They lie behind our muffin tops and help us move our trunks, compress the abdominal content, and most importantly, when strong, give us a solid foundation from which the arms and the legs can move from, which is the core strength. You get that?
Yes.
The core strength means this is solid and this can move strong. This is not solid, this can move strong. It all gets worn out faster. It looks pretty, but well, it depends. Not when I do it, but you know. But it gets worn out easier. So the core strength is important. All the muscles that wrap around the gut have some attachment to the dorsal fascia. That's that white stuff in the back. That white thing in the back. In the front, they attach to the tough fibrous tissue that reaches vertically from the pubic symphysis to the xiphoid process. What is that called? Linea alba. Such a nice thing. Let's go to the next. We don't need to look at that. That's just this band here. This thing here. Uh-oh. That's the linea alba. On the sides of our abdomen, we have two layers of diagonal oriented muscles. The fibrous directions are more or less 90 degrees. Depends sort of which part of the muscles we're looking at. But more or less they go, one goes this way, the other one goes this way. So they go, hold on. Oops. Sorry about that. They go across one another like that. That's the 90-degree angle.
Wait, which one's that?
Huh? One goes up this way, no, one goes down this way, and the one underneath it goes more or less upward from the outside in. So on these, you can see, one you can see on this side, and the other one you can actually see on this side.
I'm about to say, like, how you got that on the test?
Well, that's gonna be just, yeah. We don't worry about the test yet. First, we worry about what is what. This is great because as it comes to trunk movement, they support one another greatly. Oh, I'm going to have a great exercise in the integration exercise. Do you guys have yoga mats, anybody? Good. For the integration section, bring your yoga mats. If we don't have one, I have butcher paper to put on the ground. I figure if most people have a yoga mat, we'll have enough. I'll bring mine, you can use mine. Put the butcher paper on top of it. Anyway, what two muscles am I talking about? External and internal abdominal oblique. Great, hold on. There you go. Oh, look, there we go. So, you see, the external abdominal oblique goes sort of from the outside forward and in and down. So on the model that you're going to get is on this side on the left. And the fibers, you look at the fibers like the direction of, you can see the fibers by the lines. And on that side, the lines go like you put your hand in your pocket. So the external abdominal obliques are like you put your hand in your pocket fibers. And then the internal abdominal oblique are sort of the opposite. They sort of come from the crest and go out and inward. I mean inward and downward. And on a model, you can see that out here. They go like that. And you can see it on a model, the difference also. Well, it's first of all, when you on the test, you go like the externals are the hand into the pocket fibers. And then let's say I'm putting them here, it's like, you can't put the hand into the pocket this way. There's really weird pockets. And so then you go like, no, it can't be the external, it's got to be the other one. The other way, you see on the model, they are the ones on the right side. And then, here they're on the bottom.
Oh,
There, you take.
intestines.
Then, no, the abs. The abs. We're talking about the gut muscles, right? The abs here. So then you know it's the internal because you can't put the hand in the pocket, and also they're on the right side, and you can see a little bit of this gray thing, and that's bone. So you know it's the deeper layer as well. So that's another hint for the model when we get to the test on that. I know, huh? That's why you want all these things. Okay, the next animal is my favorite. Thinking evolutionary. It wraps horizontally around the gut. It's the deepest layer. Needs attention. So this muscle is which one?
Transverse.
The transverse abdominis muscle. And the transverse abdominis muscle, I think is on the next one, is right here. On the model is on the inside. You see the fibers go across that way? It's a fairly skinny muscle piece that wraps around and grabs our gut and compresses all that stuff. And when that stuff is compressed, it's hard as rock and you can't move, and that's a good core. And so that muscle is the big old core muscle, the transverse abdominis. So if that muscle is strengthened and the multifidus is strengthened, you're already in good shape. And we do a little side strengthening, and that's where you bring the yoga mat. We'll show you some stuff. That's a good exercise. If you do 10 times of that, you're sweating. And that means you're not just holding it, you're going up and down, forward and backwards, and you're keeping a stiff board.
Are you gonna show us, right?
Oh. No, the other one, I don't have ball exercises. I should bring my ball. Yeah, maybe. Maybe. No promise though. Yeah. I gotta first go home and practice. Not just talk about it. Almost, I think. Oh, look, last but not least, six pack. What's the six pack? The Erector abdominis. Yeah, it's really an 8-pack, but what's interesting, first goes from the pube up to the belly button. That's the first section, and then we got a few sections going up, and then on top we kind of spread it out a little bit going into the rib cage. What's interesting about this muscle is every section contracts independently, or no, not independently. Actually, they all contract together, but every section contracts, and so as a whole muscle, it's really strong because it's got these submuscles that contract. And so it's not just this whole muscle that contracts as unit, it's this contracts, this contracts, this contracts, this contracts. And all together it really contracts. The other thing that's interesting is once you activate one of those things, all the other ones activate too. So if you do sit-ups, you've got to be careful doing sit-ups. Because if you do sit-ups and you go too far up, you're going to activate a deep muscle inside called the psoas, and the psoas gives you a sore ass. we got to talk about that. When you look at the trigger point, it's like it radiates right back here. Like how many people go around, it hurts in here. And how many people will come up for check like, ugh. You can always stand up. That deep muscle is shortened because it goes from the spine to the leg, like right in here. So when you sit, it's all shortened. It's all glued together. And so when we stand up, we want to stretch out. Stretch those groins out of here because that's that muscle that wants to be lengthy. And so when you do sit-ups and you go too far up, you stimulate more of that muscle instead of the rec ab. So what I teach people is you do sit-up, like you only go like with the hand to the knee when the hand is straight. You go only till you feel like you're here contracting, and then you kind of hold it there, and then you can go back down. Don't go too far up. Or the other thing you can do is you can raise your knees up into the air when you're laying on your back, and you can tilt your pelvis up and push the knees into the ceiling. And that's really hard if you do that properly. Then you really stimulate just down in here, where it's in here, and you're not activating this other muscle because you don't give it any attachments, any firmity.
If you do a sit-up too far up, does it hurt your back or your neck?
When you do the sit-up too far up?
Yeah.
Yeah, it often activates that psoas, which gives you a sore ass.
Oh.
And so you get more sore ass, That's gonna come up. Let's go next week. The psoas.
Someone told me that sit-ups aren't healthy for the body anymore.
Well, that's exactly why. Now we understand all that. That's actually why I'm bringing that up. No, that's exactly why I don't. Okay, you got all that.